Good afternoon, everyone, and thank you so much for joining us for today's webinar, Transforming Worship and Service Experience in the Era of COVID. I am Leisha McKinley Beach, and I will be serving as your facilitator for today. I am so excited about this webinar. We have some amazing dynamic presenters. But before I introduce them, I just want to share with you why we thought this webinar was so important for our participants. On yesterday, the world news headlines were about 191 people dying in the state of Florida in one day from COVID-19. And when we think about this data, we have to remember that those individuals, they were someone's mom, father, sister, cousin, child that has lost a battle to this devastating virus. Now, before COVID, we could have entered into places of worship to remember those who have been lost and to pray for the strengths of their families and gather and assemble together and greet each other with hugs and embraces to let people know that things will be all right. But post-COVID, none of those things that allow our healing process to happen could happen. And so today's webinar focuses on those individuals and institutions where our work life is also a part of our faith life. And as we see those two overlap, we are dealing with issues around mental health and around socially wanting to assemble together in places of worship. And our dynamic presenters on today, they will be sharing information with us, both epidemiological information, lived experience of working in both HIV and faith communities, and what some of those updates are in this moment. We have with us Dr. Laura Edison. Dr. Edison is an epidemiologist from the Centers of Disease Control. She is assigned to the Georgia Department of Public Health. In her role at DPH, she is serving as the Director of Drug Surveillance, which conducts drug overdose and outbreak investigations. And in addition to that, she is also serving as a part of the epidemiology response to COVID-19. We also have with us the Georgia rock star, Miss Michelle Allen. Michelle serves as the director with the Georgia Department of Public Health as the infectious disease director. Those of you who know Michelle know by far she will always be recognized as Georgia's syphilis girl, and I have to let her tell you what that is. That will definitely keep you on this webinar until we find out how Michelle got the name syphilis girl. Michelle has truly been dedicated to the work of infectious disease, including HIV and now COVID for the great state of Georgia. And then we also have with us Dr. Tyee Link, and Dr. Tyee serves as the program director of Healthy University at Nashville Cares. Dr. Tai Link is also a minister and serves in that role at the Church of the Messiah in Nashville, Tennessee, where she is the lead servant over the HIV/AIDS and chronic disease ministry. This ministry also is a partner with psychosocial groups, Spiritual Connections, and a partner with Nashville Cares. So we are so honored to have these distinguished women from Georgia and Tennessee share with us about COVID and about its connection and relationship to our faith and worship experience. So I'm going to turn it over to Dr. Edison for her presentation.
All right, hello everybody and welcome. I'm going to talk to you very briefly about surveillance, how we actually collect information about coronavirus cases, the challenges of surveillance, and then show you a little bit of the data that's available to you and help you learn how to interpret it. So you can go ahead and go to the first slide. All right, so first I'm just going to start with a little bit of a surveillance overview so that you understand what surveillance is. Surveillance for novel infectious diseases evolves over time, and depending on the science, changes are given, and this is especially true during COVID-19. Over the last 6 months, our methods for identifying, investigating cases, and analyzing the data have rapidly evolved as our understanding of the disease changes. And I am telling you, this occurs almost on a weekly basis. This is a very tricky virus. It caught everybody by surprise, and it continues to surprise us in the ways that it finds to infect people, and the disease that it causes and the challenges of containing it. So don't be surprised when you see recommendations change. It's all based on our evolving understanding of science. But the goal of surveillance is to collect and epidemiologically analyze information to inform immediate action and guide the development of policies to limit the spread of disease, hence protecting Georgians and saving lives. And more immediately, our main goals are to identify cases and contacts to ask them to stay home during their contagious period or while they're waiting to see if they were infected to prevent the spread of disease, to identify emerging trends and hotspots that may require action, and action might be messaging or increased testing or mask ordinances or any type of intervention. Oftentimes it's outreach and just getting people to alter their behavior, and then understanding the distribution of disease in the populations that are affected. Okay, next slide. All right, so that sounds all easy, but it's not. Surveillance is very challenging. Cases are reported to DPH in various different ways. First, by electronic laboratory reports. That's how we get most of our case notifications. And these reports come in from hundreds of laboratories that send a digital file to us on a daily basis. And these data can have all sorts of issues because labs often call things by different names. They often send duplicates. They might send incomplete data. So there's definitely challenges with that. Then by thousands of providers that report directly into SENS. SENS is our state electronic notifiable disease surveillance system, where every notifiable disease condition in Georgia is reported. So most providers have access to this, or somebody in their office does, and they can report directly to us. Those data tend to be a little more complete. And then also the old-fashioned way by calling it into DPH or by fax, in which case a DPH employee manually enters these records into SENS. The challenges that we have is that the data is often incomplete. And especially when coming from a laboratory, it may even be missing an address and contact information, which makes it really hard to take immediate public health action and presents many challenges. Another challenge we have is that COVID-19 has exponentially increased notifiable disease reporting and response in Georgia. Our COVID-19 is way more than all of our other notifiable disease conditions put together. So we've had to really rapidly increase our resources, particularly our human resources, in order to address this. We have hundreds of staff that work to review, clean, and complete data through data quality checks, data matching, and case investigations. And surveillance data is inherently messy. And that's one of the reasons why you may look at the website one day and see that on July 15th, there were 3,400 cases reported, and the next day it may say 3,359, and that might be because we found duplicates or realized the case was misclassified, or various different things that might change, make that change. And it really requires investigation through contacting providers, reviewing medical records, and talking to cases or their family in order to complete these records. All right, next slide. All right, so there's a lot of different data out there, and it can be hard to know what to look at. So I'm just going to walk you through a few things that I tend to use on a daily basis to take a snapshot and see where we are. Most, but not all of this is publicly available, but we are working on getting it all publicly available. And I'm going to just talk you through these, and then I'm going to show you some examples of data that's out there. So first, new case and death trends at the state and county level are really important. And I say trends instead of counts for a very important reason as well. We know that based on the science that's out there, that we are probably diagnosing and identifying about 1/10 of the true cases that are out there. So if that's the case, looking at the exact numbers is not always the most important thing, but looking at the trends. Are we going up? Are we going down? Are we plateauing at a high level? And what's happening on the county level as well. The 14-day incidence rate. Now, a rate is the number of cases per population. In this case, we use 100,000. And it's very important to look at that when you're comparing different areas, because a rural county may have only had 10 cases last week, but they might have a really high rate because it's a sparsely populated county, where Atlanta may have had 2,000 cases last week, and their rate might actually be lower because of the high population here. So that's important to look at. If you look at the most recent 14 days, it gives you a snapshot of how things are looking right now, as opposed to looking at the whole epidemic over time. Percent positive PCR tests. So we look at of the tests that are reported to us, how many of them are positive. And this is important because we know that if we have more of it in the community, the percent positive of the test is going to increase. More people are going to be positive. Hospitalizations are important for many reasons. One, they don't care that much about the number of tests we're able to do. Most people who are hospitalized are tested at this point. So it can be a good indication of severe illness. And also knowing if our hospitals are approaching capacity or being strained is very important. And when that happens, it's very important for people to alter their behavior. Ventilator capacity is another good indicator because a lot of people that are hospitalized with COVID need to use ventilators. And then demographics to see who this is affecting, and we hope to be able to share some county level demographics as well, because that definitely changes a lot from county to county. So that's some of the stuff I look at, and a lot more data is available on our website. If you go to our main DPH webpage and scroll down, you'll see the daily status report, and that is updated every day with current data. All right, next slide. All right, so this graph is one of the first things I look at every day, and this is cases over time. The blue bars are the number of cases that were reported each day, and the yellow line is just an average because it takes out some of the day-to-day variation. This is interesting to look at some of the markers on here. You can see at the very beginning when cases started going up, we had a large gathering ban, and then in early April, we had our shelter in place, and we peaked shortly after that, but then it was working and we were starting to go down. Then in early May, shelter in place was extended for people at risk, but it went away for a lot of other things, and we began opening up. And there was a bit of a lag, but we've seen a really sharp increase in cases mainly through July. And I see at the very top there that things could potentially be leveling out, but it's a little too early to go. All right, well, on the previous slide, you also had the option to select by county. And you also, so you can look at that trend for any county. You can look at the county you're in and see how things are going. All right, and now these are some maps that are on the website. These were actually just added to our website yesterday. Or we changed the way we were presenting things. We added this 2-week map so you can see where the rates are the highest in the last 2 weeks. And we're really seeing South and Southeast Georgia light up, but most of the map is yellow, or a decent color of yellow to orange, and this means that the whole state is really pretty much in a bit of a crisis. CDC says anything over 100 cases per 100,000 in 14 days is considered a very high level of transmission, and with the exception of about 3 very rural counties, the entire state is in that. So you can look at this. You can look at the cases, total cases over time since the beginning of the epidemic. You can look at the total cases per 100,000 from the beginning of epidemic, and same thing for deaths by clicking on the tabs at the top. So I recommend you look. It's interesting to see the differences between the counties. You'll notice if you look at just the cases as opposed to the rate that it really highlights the urban areas where we have dense populations in most cases. But then when you look at the rate by population, it definitely extends out into rural areas. Okay, next slide. All right, so testing. I had mentioned before that it's important to look at percent positivity. This top table is on our website. We show the total PCR or molecular tests. We have descriptions under these little information buttons about what those mean. But PCR tests say that you have a current infection. And we also show the PCR tests that were reported today. At the very bottom column, you see percent positive. And the World Health Organization says that you need to have below a 5% positive in order to hope to contain the disease. Well, over the entire course of this epidemic, ours is 10.8, and most recently it's been 14.1. So we are at a very high percent positivity rate, indicating widespread transmission. In the right-hand column, we have serology, and a serology test tells you that you have been exposed to the virus, but you don't have it currently. And what we hope is to see that percent positivity go up over time, meaning that we have more immune people in the community. The bottom graph is, we're working to get on our website, but it's not there. And this looks at the number of tests that were done over time by the sample collection date. The last 2-week drop off is just a result of the lags in testing. So our testing has not actually decreased. But the little dots show percent positivity, and you can see at the very beginning in March, our percent positivity was very high because we were testing only very targeted people who were hospitalized and severely ill or had known exposures. But then we started opening it up to testing more people and even asymptomatic people. And we started to control the virus and in late April and early May. And you'll see the dots start dropping down and got real low. And then as our cases rose, it's been going back up again. So we are in a pretty bad place in terms of our percent positivity right now. And as we start controlling the virus and people stay home and wear their masks, we should see that start dropping off. All right, next slide. All right, hospitalizations. This is a daily count of the number of COVID hospitalizations as reported by hospitals to DPH. And again, throughout April, when we had our first peak, they were getting fairly high, and then they went way down by the end of May and June. And then as cases started going up in July, hospitalizations have as well. We're now, hovering over 3,000, and a lot of hospitals really are being strained by this, and we are desperately hoping not to see this number continue to increase. Okay, next slide. And this is ventilators in use, the number of ventilators. You see a very similar pattern here to the hospitalizations. was high in April with our first bout, went down again as our case counts decreased, but is now quite high. And again, we're really just hoping not to see that continue to rise. DPH does provide ventilators from our stockpile to hospitals, and we have been having to send those out on a daily basis. All right, next slide. All right, so demographics. We have various demographics on our website, and I'm just going to present a couple of things here. This is an interesting graph. On the left-hand side, you'll see the age categories. Then the blue lines are the number of cases. The yellow lines are the number of hospitalizations, and the red lines are the number of deaths within those categories. And what you see is that the most cases occur in younger people, age 18 to 29, and then slowly decrease. The most hospitalizations occur in 60 to 69-year-olds, but most deaths occur in those 80 and older. Not an unexpected pattern, but it becomes very clear when you put these numbers together. All right, next slide. All right, this is a snapshot of some demographics. We have age categories, we have race. On the right-hand side, you can see that most of our cases are white, but this is a count. And if you actually look at the rate, which we're working to get on there, the rate is higher among Black people than white people. We have cases by sex. Most of our cases are female. And then we have cases by underlying condition, and about 23% report an underlying condition, 25% report no underlying condition, but that unfortunately that data is missing in about half the cases from incomplete case reports. And then next slide, please. This is the same thing for deaths, and there's some definite changes here. The deaths occur mainly among older people. The difference between white and Black changes a little bit, and the death rate among Black people is higher than among white people. And then we have actually slightly more males have died than females in Georgia. And if you look at the deaths by underlying condition, and by underlying conditioning, these are things that we look for that would make people more susceptible to being severely affected by COVID, such as heart conditions or immune conditions or lung conditions. There's various conditions we look for. We see that 64% of people that have died had an underlying condition. Only 14% didn't, and then 22% is unknown. So it's interesting to look at these data. It's interesting to compare them side by side. Most of this information is available on our website, and we're working to share more. And if you have need for data for other purposes, we can always provide data through our data request system. All right, next slide. All right, and that is my email address. As I mentioned before, on our website, you can find more data. There's also information about testing that's sponsored by the state. It's free testing. Every health district runs state points of collection, and you can find phone numbers to schedule appointments through our website as well. And we have a lot more resources on there. We have a lot of guidance for different audiences, what to do if you're exposed, what to do if you are sick, links to CDC guidance. So if you haven't been to the website, take a little time to explore it. If you need a test, go to the website as well. And if you have data questions, feel free to reach out. Thank you. I'll turn it over to the next presenter now.
Thank you so much, Dr. Edison. I would like to thank the organizers and the facilitator for the invitation to join you. It is an honor and a privilege to be with you, and I'm ready to go. The church has left the building. A lot of us are wondering, how do we return to worship without spreading COVID-19? So I want to walk you through this slide and others to talk about how we can do that safely. So I want you to think about some important things that you have heard. One is cleaning, disinfecting, and also social distancing. When we are in church or places of worship, we often consider the distance to the left or the right. But when you think about 6 feet, I want you to understand that this is more than one direction. Sitting 6 feet away from somebody on the same row is not enough. You need to consider the distance that is behind you and also in front of you. So that is very important. One thing that we're not accustomed to is being in a worship place without touching, whether that is hugging or shaking hands. Many of us are very familiar with the phrase, turn to your neighbor, turn to your other neighbor. And we want to think about, as we return to worship, things that we can do to cut down on the spread. Also, it's very important to think about how to make it clear 6 feet designations, signs that show that you're 6 feet away from something. You may also want to put signs up that limit how many people are in a bathroom. If there's a bathroom with 3 stalls, I certainly would not encourage you to have 15 people waiting. But if signage is on the outside, clearly limiting the number of people on the inside, that is going to help. The other thing, and you've heard this from Dr. Edison, you've seen this from the news, wear a mask. And who should wear a mask? Attendees, staff, volunteers, all those who are present. Cloth masks are also acceptable. It doesn't just have to be a surgical mask. Next slide. How to prevent the spread. Now, when you think about signs and symptoms, a lot of us think about coughing, sneezing, fever, shortness of breath. There are other signs and symptoms that have also been added, one being a headache and loss of appetite. If you are not feeling well, please stay home. If you are not feeling well, I repeat, please stay home. Oftentimes we think about we would like to be a part of the worship experience. Many churches have had a lot of participation as it relates to virtual service. I've seen some drive-through services where people stay in their cars and they worship together. But if you are not feeling well, it is very important for you to remember to stay at home. Next slide. Things that you need to know about COVID-19. One thing that I would ask you to think about is how you can share quick nuggets within your social media. You may want to share, get tested. You may want to share 6 feet apart. You may want to share things that would allow people to be reminded of the things that we can do to protect ourselves. We know that this virus is very infectious. And one thing that we also know is that face coverings have proven to be very effective in reducing the spread. As you see here, as I talked a little bit about on the last slide, there are a lot more symptoms than the few that we thought about when we first heard about it. And you see that here's a list of those symptoms. I would encourage you to get tested if you have any experience of any of these symptoms. If you know someone who does, I would also encourage them to get tested as well. Next slide. So if you test positive, what should you do? If you test negative, what should you do? I want you to pay attention and know that there are some things that are consistent. The face covering is consistent whether you test positive or negative. Certainly self-isolation is important. And one thing that I have heard that I would like to stress is some people are getting tested and then not isolating and not using social distance because they're waiting for their test results to come back before they do so. Keep in mind that it is very important to not only protect yourself, but you want to protect others. If you have recently gotten tested, especially if you were tested because of a close contact, go ahead and self-isolate and prepare yourself if your test results are positive, that you have not exposed any more people, but also if your test results are negative, that you continue to practice social distancing. If your test results are positive, you will be contacted by the health department, and I'm going to talk a little bit more about contact tracing on the next slide. Something else that I would like to point out before we leave this slide is that you want to make sure that not only are you washing your hands, but you are avoiding touching your face, your eyes, your nose. Many of us do not realize how often we touch our face throughout the day. And you want to be very mindful of that. I know for some people it's a little bit different to think about being so cognizant of washing your hands and wearing sanitizer, but honestly, this is a very important practice that we should keep up independent of a COVID-19 pandemic. Next slide. Contact tracing has gotten a lot of attention in the media lately. I want y'all to know that contact tracing is not new. It is a tool that public health has used, and it has been very effective. I have worked in the field of public health for a while, and contact tracing has been a part of my life for more than 20 years. I have heard some people say they thought that it was the responsibility of the agency if something happens. Well, my job said that there was a case. Should my job be doing contact tracing? I heard there was a case in my church. Should my church be doing contact tracing? That is the role of the health department. Even since we've been on this chat, I noticed the post that someone said a person had COVID-19 and they were never contacted. I'm going to share my contact information so we can make sure that that happens. Contact tracing is confidential. Once you have a health department reach out to you, everything will be confidential. It will be HIPAA protected and compliant, like all the other information we receive. We will notify your contacts that they've been exposed and instruct them to self-quarantine. We will also provide information on where they can go to be tested. If you're wondering, well, when has someone been using contact tracing before? HIV, TB, syphilis. I saw Alicia gave me a shout out about my nickname Syphilis Girl at the beginning. So I want you to know that contact tracing is something that we have been doing and something that we need to do. Another thing that you can emphasize as you come back into your worship places, if someone says the health department has reached out to me, please call them back. Please participate. Next slide. We are also in the middle of an initiative to end the HIV epidemic. This was something that was announced out of the White House during a State of the Union address. And it is very important that you understand how we can work together to achieve the goal. We have 4 pillars: diagnose, treat, prevent, respond. You see the goal to the left is 75% reduction in new HIV infection cases. This is very important to think about. Many of us have been a part of conversations about HIV and COVID and what it means for a person who may already have a compromised immune system. As you've heard a lot, even Dr. Edison mentioned about underlying conditions. I want you to understand that if we follow these 4 pillars, we're going to see a tremendous impact in the epidemic. And always remember that prevention is a cure. Next slide. We had a meeting with representatives from HHS, and they asked us in the state of Georgia if we would be interested in establishing a faith-based coalition. Many of us have coalitions that have faith-based members present, but at this particular time, we did not have a faith-based organization in our state that worked exclusively with HIV. If you are interested in your church or you working very closely with this, please reach out to me after the presentation. We do have some churches and leadership who's already stepped up to say they would like to help us and they want to be a part of organizing the effort. Very excited about it. We want to identify the opportunities to work with faith-based organizations. Many of you who do this work may have had HIV testing at your churches, or you may observe days like World AIDS Day or National HIV Testing Day. We would like to be strategic in our response to end the epidemic, and we also would like for it to be something that is ongoing, independent of a particular initiative, but that we are always working together as a community. Next slide. We are stronger when we march forward together. I have my contact information available. This is a very powerful quote from Dr. King, and I want you to think about what it means. I heard somebody say of the COVID-19, Michelle, does this remind you of HIV? And I said, as a virus, no. As an epidemic, yes. I want you to know that if we work together, we're going to have a much more formidable impact than working separately. Thank you for your time, and I'll be around later for additional questions. I will now turn it over to the next speaker.
Hello, well, thank you for the opportunity of being invited here today. We have some great information. So I would basically at first like to explain my social location or my personal identity so you can understand where I am speaking from. As a Black cisgender female living with HIV for over 15 years, and I define myself as a Christian, so my book of knowledge is the Bible. So I would like to start off there. Slide 1. Next slide. I also would like to talk about some definitions. We're talking about faith and we're talking about worship, and the corresponding action for worship is service. So I want to talk to you a little bit about what faith-based organizations can do during this time that we're dealing with this pandemic. And then I would like to talk to you about the application of the faith, the opportunity, and the service. Next slide. We've already heard some information about HIV, and this is some information about HIV in Tennessee, Nashville, Tennessee, and about COVID-19 in Tennessee. In both instances, the Black community, or the communities of color, are disproportionately affected by both viruses. And that's what sticks out, that the church now has an opportunity that maybe it didn't take as much with HIV now to deal with some like incomes that both viruses are having. Next slide. Although both viruses are different, there's some similar behavioral outcomes for both. Both can be avoided in many cases by certain specific procedures. Sometimes it's unavoidable, but in many times, both HIV and COVID-19, following some safer procedures, both can be avoided. Both may be asymptomatic, meaning that you may not be able to see that someone has HIV or COVID-19. So the assumption is if you follow the procedures that both can be avoided. Both carry a stigma attached with it. There's more of a stigma, I would say, with HIV, but there's a stigma also attached with COVID-19 that I see. And then people of color are disproportionately affected with COVID-19 and with HIV. With COVID-19, it may be because some communities of color are not easily able to socially distance. It may be because of the intergenerational living. It may be because many workers within those communities are essential workers, and many of those people cannot work from home, which sometimes is the option. And then I see in both cases, self-advocacy is sometimes required. There are many cases that with HIV, I hear of many people that went to the hospital, went to their medical providers, and because they weren't in a certain population, that the doctors didn't take them seriously with give them an HIV test until they were almost near death. Same thing with COVID-19. I know of many people that went to the hospital, returned home, transferred COVID-19 to their entire families, and then they were taken serious. So self-advocacy is a mandate in both situations. Next slide. So to talk about some definitions that we're talking about today, one is faith. And sometimes that term is used very loosely. But faith is a trust and a confidence, and a little more than that, it's an assurance. And there's a belief in something or someone. In my case, I have a belief in the Christian faith. And so it teaches that faith is the substance of things hoped for, the evidence of things not seen. And with that faith, you have an opportunity. with the set of circumstances that we've been given, there's an opportunity, and it makes it possible to do something. The doors are closed, like many people have said already. The buildings, most buildings are closed. Most cities have a mandate, especially in the South, that you can't meet over 50. And the churches that have opened, there have been many people that have come away with a positive diagnosis. So we have an opportunity to do something, to think outside of the box. With that worship and that faith and the opportunity, the corresponding action is service. To have a sustained effort for a purpose. And that purpose initially can be to meet the needs of people where they are now during COVID-19, but post-COVID-19, many of those people won't return to the same churches, and they'll still have the needs, and the needs will be increased than they are now. Next slide. So we're at a place where there's a cultural shift happening. That's already started, that's already been in motion. And in many of our communities, because of the accumulation of disadvantage, racial injustice, you add to that social determinants of health, many of our communities have been left discouraged and isolated. And so the faith-based community must have a responsibility and a mandate to take up the cause, because in Jeremiah 22:16, it says that's what it means to know God, that there's some action that must be taken, and it can't be just meeting the needs spiritually or just because the doors are closed. So it has to extend beyond that. The Bible also teaches that faith without works is dead. So it's some action that must go to the faith that you have believed in, because the doors cannot be opened anymore. So it must extend from the outside. Next slide. So it's a time when you can't be silent. There's no safe choices. If the church or if the faith-based organizations are going to be relevant, there's something that needs to be said. I'm taking a text from the book of Esther, and she was a person taken outside of her. She wasn't in a dominant culture. The dominant culture actually took her people hostage. And her uncle came to her and said, if you remain completely silent at this time, relief and deliverance will arise for the people of God from another place, but you and your family's house will perish. Yet who knows whether you have come to the kingdom for such a time as this. And that's to faith-based organizations, whether you're Christian, Muslim, or whatever it is, that the time is now for people to speak up and not be silent. Because if you're silent, you're actually adding to the problem. Some examples of some of the service that we have done at my church, like many churches, we have had Facebook Live services. We also had our departmental meetings through Zoom, or through our youth ministry has also been through Zoom. We've connected with members by phone and social media. We've had drive-through food distributions in conjunction with Nashville Cares. And there are other resources out there that we have directed our people to for different produce distribution sites. Connecting with community members through community resources, partnerships with ASOs. So many times we have looked in the past, well, this is not a Christian organization or a Muslim organization or whatever, that you believe in, but a partnership with an ASO or a CBO to facilitate virtual groups, because there's some commonality in there that it could be mutually beneficial to both groups. Facilitating groups in the park where there can be social distancing, forming one-on-one virtual connections with members. And this has really helped us out a lot, because a lot of our members, as well as a lot of my clients, didn't know how to facilitate telehealth. It was offered to them, but they didn't know how to use it. Some of them had smartphones, but they were scared of the technology. So just a one-on-one virtual connection with another person and seeing the face of another person can help them through a crisis that they're having. I know within HIV, we have tried so hard to get people out of isolation. Well, we've had to put them back in isolation. So what do you do with that? With a person that in isolation they might perish, literally perish. We've had some suicidal tendencies for some of our clients because of the isolation. So that means if I have to have a virtual meeting with you every other day, that's what we're going to do, just so I can see your face. So, and also use professionals within your organization. So within our church, we have doctors and we have therapists that we can use. So using the people who are already in the house to minister to the communities that are around you. Next slide. And so this is a research that I got from the Pew Research Center that says during this crisis, people have strengthened their faith even more, which is more of a reason that the people of faith need to get out there to the community. We can't always wait for people to come in, especially when the doors are closed. But we know that people need socialization. They need some connection, and this study shows that their faith has strengthened during this crisis. So how do we take opportunity and advantage of that? Next slide. Again, strengthen community networks. So one thing that we have done with our, we have a HIV ministry that we partner with Natural Cares who gets the grants, who gets some of the grants that they can pass on to us. And in this collaboration, we can also provide a meal to our people through Uber Eats. And some of our people have never used that, but we virtually get on for our study. And then Uber Eats comes and delivers the meals, or a Grubhub voucher. So there are some very creative ways that we can minister to the community and to our people in collaboration with the ASOs and CBOs that are in our communities. Next slide. And so as I look at a faith-based organization, I don't look at it only as a spiritual connection. There should be a spiritual connection. There should be a mental connection, meaning sometimes you can pray for somebody and sometimes you need to refer. So there should be a mental connection within your church body. The physical connection, we have people within our community that are strength trainers, that are sports trainers. So we want to help the total person. We don't want to just minister to one side of the person so they're lopsided. And then the economic portion. You know, we don't want to, for many years you've heard, bring your tithes into the storehouse, but what do you do with that? If you do that, what do you do with the 90% left, or whatever is left? What do you do with that? And so that's important. Next slide. I'll say my last slide is when Esther made the decision to speak up, which was against the law, which many times may be against the law that we have. She said, if I perish, I perish. And that wasn't a thing of she's given up. It's like she understood the danger of speaking up, but she also understood the benefit, and that is something that she had to do. In the words of John Lewis, nothing can stop the power of a committed and determined people to make a difference in our society, because human beings are the most dynamic link to the divine on this planet. And so my suggestion is, let's start some good trouble. Thank you.
Thank you so much, Minister Link, Michelle Allen, and Dr. Edison for such rich information. And I know that the questions are coming in. We're going to try to answer as many of these questions as possible. Darian, do you have some that you want to start with?
Let me see what we have in our chat, what I have in my chat box. We do have one for, Dr. Tai E. They really want to know, how are you all providing, service in the HIV ministry without, seeing people at your church? They heard about, you all doing telehealth at, say, Nashville Cares, but they asked about the telehealth experience with connecting folks while you're not at home at your home church.
Okay, so we already had a ministry that was going monthly, or a support group. I like to call it an empowerment group that was meeting monthly. And so we continue to meet. We meet virtually. And we meet through Zoom or to GoToMeeting, one of the social platforms. And we also can provide meals that are delivered to their houses. And that's in partnership with the grant that we have at Nashville Cares. So the importance of partnerships is maybe the faith-based organization in your neighborhood won't always have the resources, but when you partner with a community organization, together you can provide a complete service for the individuals that need it.
And Darian, I have one question here for Michelle. Michelle, this is actually a two-part question. The first part is the department available to host, looks like either host a webinar or speak with pastors or church leaders, maybe during their online Bible study or worship experience, about what it will take to open the church up? And then the second part of the question is any advice or suggestions for seniors who want to enter into their place of worship, who may have comorbidities?
Thank you for the question, Leisha. The first question is, we have been contacted by several bodies to participate, and sometimes we contact the local boards of health to make sure that they are a part of the conversation. There are many churches that have established strategic reentry teams, including my own church family who is on the call with us. And also, as it relates to seniors, y'all, we want to make sure that we get the information out in a relevant way and make sure that everyone understands. Whether you are a senior or someone with an underlying condition, we are going to encourage you to protect yourself the same way. Certainly, there have been recommendations that members of the senior population should social distance or perhaps not return to church. I am encouraging all seniors that I know, even as things have opened back up and we have released some of our shelter-in-place strategies, to limit being out unnecessarily. But when they are out, if they would use face coverings and protect themselves, I think that's a good idea. And I think that is the exact idea that we need to take as we return to a place of worship. In fact, what we would normally say in public health is if you treat everyone like they have COVID, that will help you understand how to protect yourself. Meaning that if someone had COVID and it was a loved one and you were around them, the first thing you would think is, I would not want to be around them without protecting myself, because I wouldn't want to have them in a situation where they were exposed to other things that complicated rather their infection, and or they would also think the same of you.
Okay. All right. Thank you so much for that. Darian, any other questions on your end?
Yeah, someone was asking because they were you talked about, this question is for you, Michelle, about the coalition that you're developing here in the state of Georgia with faith leaders. And some other faith leaders in some of the other parts of the South were curious on if you all were thinking about expanding or, to include maybe make it a regional thing, or if how could they possibly get in touch with you, or how could they replicate this in other areas?
I would welcome the opportunity to have that conversation. Certainly, we are at the beginning stages. We are excited. We do have good momentum behind the idea of doing something like this. And I think that we would be very open to what it would look like to have a regional presence. There are a lot of things that when we work in public health, we know that there are commonality between contiguous states. And so that is certainly an opportunity for us to work together and share lessons learned because we have similarities in our region. So certainly, I would want to make sure that my contact information is available. I think on my slide, I had not only my email, but my cell phone number. I definitely want to make sure those conversations continue.
Absolutely. And, quick plug for Emory Compass, we are certainly, here to partner with you all and definitely create some type of regional presence when it comes to working with our faith-based leaders around HIV, and then as well as COVID as well, with this being our new normal, and this is what we're dealing with across the country. But the South has definitely been hit hard, like we have been with HIV. And I know that we are getting ready to close, so just want to leave it open if there's any last burning questions out there. We have about 4 minutes because we want to make sure we're conscious of everyone's time. And I also wanted to drop in the chat our evaluation that you all will be getting via email. But if you'd like to go ahead and, start your evaluation now, you are more than welcome to do so.
Okay. And as we are preparing to close, again, I'd like to thank Dr. Edison, Michelle Allen, and Dr. Link for the information that was shared today. The one thing that remains true about our Southern experience, and that's hitting us hard on both ends. One is we are lovers of football, and we believe in our worship experience. And so this virus has hit on both ends of those, and it was such a rewarding experience today to hear from all of you and to see how we are still able to provide service to our community, and that even having a worship experience in person is not out of the question, but having faith institutions assess risk, assess the ability to prepare the building for a worship experience, and using those tools that are provided for us is a great resource that now we all can share with our faith colleagues and our faith leaders. And so we're going to close on that note. Thank you so much for participating on today's webinar. And if you have any questions for our dynamic presenters, they have added their contact information, I think, throughout the presentation. And Darian will also include their contact information as we send out evaluations and things of that nature to you as well. Well, this concludes the webinar for today. Thank you so much for joining us.
Thank you, Ms. Beach.
Thank you so much. I really appreciate you all.
Thank you.